And the next session is on the advantages and disadvantages of GnRH antagonist. For this, we have Dr. Peter Kovacs from Hungary. He graduated from Albert School of Medicine in 1994, and he did his OB/GYN training and subspecialty training in reproductive medicine from New York, Albert Einstein College of Medicine. After that, he joined Cali Institute of IVF Center and later on the medical director of the center. His area of interest focuses on stimulation options for IVF, predictors of IVF outcome, and on various tools that could be used to improve laboratory and clinical outcome. He has published 40 peer-reviewed international papers and several book chapters.
So my first presentation is about the pros and cons of GnRH agonist or antagonist stimulation. Now, IVF has 3.5 decades of history. The first baby was born in 1978, and since then the in vitro fertilization has undergone tremendous changes. Initially, the cycles were done in the natural cycle, and then oral agents were used to increase the egg yield. Then urinary gonadotropins were added to further increase the egg yield. Now, a major breakthrough was the introduction of the use of GnRH agonist, which resulted in a significant reduction in cycle cancellation, but also introduced something new, ovarian hyperstimulation, which became a lot more frequent after that. Now, this was followed by the use of recombinant preparations instead of the urinary preparations, and then by the combination of GnRH antagonist into the stimulation. And over the past years, we seem to go back to the beginning, and we are using less medication, going back to milder stimulations, even to the natural cycle. Now, before we can design a stimulation protocol and decide on what medications to use, we need to know what happens in a natural cycle. And in the natural cycle, there are two processes that occur in parallel. One is the maturation of the egg, and the other is the buildup of the endometrium. The functional unit responsible for both of these processes is the ovarian follicle, and the activity of the follicle is regulated by multiple endocrine, paracrine, and autocrine mechanisms. Now, this slide is rather busy, but it describes the two-cell, two-gonadotropin theory that was put forward many decades ago. It is the hypothalamus that generates the GnRH that stimulates the pituitary, which will release the two gonadotropins, FSH and LH, and they will bind to the receptors on their target cells within the ovary and will increase the activity of those cells. Besides the two gonadotropins, and I'm not going to go into details, there are a number of other cytokines, growth factors that regulate within the ovary the control of the follicle growth and contribute to the feedback mechanisms for the complex regulation. Now, GnRH is a decapeptide. It is synthesized in the arcuate nucleus of the hypothalamus. It is released in a pulsatile fashion, and the pulse amplitude and frequency changes from the follicular to the luteal phase. It has a short half-life, about 2 to 4 minutes, and this is mainly due to rapid cleavage between certain amino acids. It mediates its effect via surface receptor, and ultimately it modulates ion channel functions. Now, if we alter the sequence of the amino acids, we can extend the half-life of GnRH agonist, and it becomes clinically available. It is available as an intramuscular, a subcutaneous, or an intranasal product. It can be administered daily, or there's a depot formulation. If we extend the half-life of GnRH agonist, when it binds to the surface receptor, the receptor ligand complex will be removed from the cell surface, and the receptor and the effector system will become uncoupled. And if we prolong the administration of the GnRH agonist, ultimately we get a hypogonadotropic condition. Now, despite the use of GnRH agonist in about 3% of the cycles, still a premature LH rise can be seen. GnRH antagonist is also created by multiple substitutions of the original GnRH molecule. It has a different mechanisms, and we heard this earlier today. It competitively binds to the receptor, so the receptor stays on the cell surface. Its effect is immediate, but its effect is also reversible. And just like with the GnRH agonist, in a few percent of the cycles, we still see premature LH use despite its application. This slide is probably not too easy to read, but this just describes the various stimulation protocols, so I'll jump to the next one. And I will not go into details of the various stimulation protocols, but the GnRH agonist can follow the long protocol, the luteal long, the follicular long protocol, follicular short, and the luteal stop protocol. They all meant to be used for different patient populations, and they all utilize GnRH agonists besides the gonadotropins. Now, the GnRH antagonists can also be used following various stimulation protocols. People may use the flexible or the fixed start. With the fixed start, GnRH antagonist is started on day 6 of the stimulation. With the flexible start, usually a certain follicle size and estradiol level has to be reached first before the administration of the antagonist. It can be started early in the cycle, day 1, day 2 of the cycle, and you can give a single or multiple dose preparations. So now that we have many different stimulation protocols, and when a new medication, a new combination of medications or a new stimulation protocol is introduced, we have to test and we have to compare it to the standard stimulation to make sure that it is as effective, if not better, than the standard stimulation. So the GnRH antagonist, results with the GnRH antagonist stimulation were compared by a number of studies to the luteal long stimulation. And early on, it was found that there was about a 20% lower chance to achieve a pregnancy. And back then, this was considered a significant difference according to this 2002 meta-analysis. Now, people quickly came up with various explanations for this. They partly explained it with the different hormonal changes induced by the antagonist when compared to the agonist. They explained it that it induces a different luteal phase that may be responsible for the fewer pregnancies. Obviously, there's a learning curve. When we try something new, we have to find the right patient, we have to find the right protocol for it. So it was thought that maybe the ideal way to use the antagonist was not found, and this was responsible for the lower pregnancy rate. So in the past, a little bit over than a decade, a number of studies evaluated whether certain aspects of the antagonist stimulation leads to superior results when compared to other aspects. So I mentioned that the antagonist can be started fixed on day 6 or based on follicle size. And this approach was compared by multiple studies. And I will not, you can read on the slides, I will not go into the details of all of these studies. But typically what one can say that with the flexible start, a little bit less gonadotropins are used. Stimulation outcome is similar, and pregnancy rate is similar. And this is supported by the individual studies, as well as by a meta-analysis published in 2005 that found no significant difference in the pregnancy rates with the fixed versus flexible antagonist stimulation protocol. GnRH antagonists can be administered as a 1/4 milligram single daily dose, or it can be administered as a 3 milligram depot dose followed by 1/4 milligram doses from the 5th day onwards. And again, when different stimulation approaches are available, you have to compare them to see which one is better. Obviously, the patients would prefer the depot version because it means less injections for them, and they certainly will prefer it if it leads to no difference in the stimulation outcome. Now, one difference is that when the depot version is given, the 3 milligram dose is given, it leads to an even more profound suppression of LH. So these patients need a little bit longer stimulation with more medications. But when we look at the clinical outcome, the pregnancy rates do not seem to be affected by the single versus multiple dose. Now, one of the benefits of the GnRH agonist-based protocols is that it allows some flexibility with the cycle start, because once you have achieved suppression, you can continue using the agonist and decide on a certain date to start the stimulation. Obviously, it would be nice to have the same kind of flexibility with the antagonist stimulation. So rather than starting it on day 2 or day 3 of a spontaneous cycle, if we could somehow program the treatment it would help the clinicians, the patients as well. So an easy way to do this is by putting the patients on contraceptive pills before the stimulation is started. There are certain benefits attributed to the pill start. The one that I just mentioned, that it allows flexible cycle start. It results in a more homogeneous cohort of follicles by eliminating the late luteal, early follicular gonadotropin rise. There's less cyst formation or dominant follicle formation. But contraceptive pill can be associated with side effects, and we also need to study whether this has an impact on the clinical outcome of the treatments. So again, various studies looked at this, and these studies found some differences in the stimulation outcomes. Certain studies noticed that the stimulation was longer among patients who were put on the pill first. Other studies found that patients who were put on the pill needed more gonadotropins to get to the egg retrieval. But there was no difference in the embryo availability and the clinical pregnancy rates, which is the most important outcome of all of these. If we combine the results of studies, and in the previous presentation it was discussed that meta-analysis can be looked at as the pyramid, or the pyramid of the studies as a very strong evidence. Some people would argue with that if you include poor quality studies, then you will have a poor quality meta-analysis. This is two meta-analyses from the same author. One included 4, the other included 6 studies with a little bit different outcome. And the meta-analysis found the second one, the updated meta-analysis, that when contraceptive pill was used as preparation, the pregnancy rate was reduced by 20% in those cycles. Now, we need to point out that there are differences among these studies, because there's a pill-free period included after the last pill and the stimulation start, and it varies anywhere from 2 to 5 days, and this could be an explanation for the individual studies not finding a difference in the pregnancy rate, while a meta-analysis showing a difference. Now, rather than using contraceptive pills, you can use estradiol tablets in the luteal phase. And when estradiol tablets are used, considering a 28-day cycle, typically they are started on day 23, 24. It's 4 milligrams daily up until menstruation. And again, you can extend it beyond day 1. You don't have to start the stimulation right away. You can continue using it. So the estradiol pill has the benefits of the contraceptive pill, and also allows flexibility. A few studies looked at the efficacy of this approach, and again, similarly to the pill, it was noted that a little bit more gonadotropins was needed, an extra day of stimulation was needed, but unlike with the contraceptive pill, there was no difference in the clinical outcome when estradiol was used as preparation. Now, I mentioned in the beginning that when the GnRH antagonist is used, it results in immediate and profound suppression of LH, and we know that LH is needed for successful stimulation. A threshold and ceiling levels of LH were established, and some of these patients actually have below threshold LH levels once the antagonist is started. So the question is, if we increase the dose of gonadotropins with the antagonist start, whether we can improve the clinical outcome or not. Some studies looked at this, and they found that there was no difference in the pregnancy rates, and there was no evidence for a need to increase gonadotropins with the antagonist start. Now, other studies looked at that rather than increasing the antagonist, what happens if we supplement extra LH and extra 75 units of LH with the antagonist start, since it is LH that we profoundly suppress. And again, some of these studies actually even used the depot formulation, so the 3 milligram of the cetrorelix, and found no benefit with LH supplementation started with the antagonist when they consider the pregnancy rate as the outcome. Now, an interesting study which was published in 2011 by Bosch et al., they looked at subgroups of patients, and while overall they found no benefit with LH supplementation, among older patients over the age of 36, they did notice a trend for higher pregnancy rate and higher implantation rate when LH was supplemented. So again, we can conclude that neither the dose increase of HMG nor the supplementation of LH makes a difference when it comes to the clinical outcome, but certain subgroup of patients may benefit from this approach, so this is something to be considered for older women. Now, the question also is, who are the ideal patients for the antagonist stimulation? Is it the normal responder? Is it the high responder? Is it the poor responder patient? So the GnRH antagonist approach was studied in high responder patients. And in these cases, often the GnRH antagonist is started with stimulation on day 1 or day 2. And what was found that with GnRH antagonist compared to the long protocol, there was a quicker stimulation, less gonadotropin was needed, there was a lower peak estradiol level achieved, but there was no difference in the clinical pregnancy rate. And another very important finding is that with the GnRH antagonist protocol, there was a significant reduction in the hyperstimulation risk. Now, the poor responders are a challenge for all of us, and this is probably the group of patients where most stimulation protocols and most drug regimens were attempted. And the literature is quite mixed. And again, I listed a couple of studies, and these studies are contradictory to each other. They all agree that the pregnancy rate in this group of patients is rather low, and it's impossible to draw conclusions whether one stimulation is superior to the other. So the antagonist stimulation, antagonist-based protocols can be considered just as well as the short or the long stimulation for these patients. Now, once we get to the end of the stimulation, once we reach the certain follicle size when we are ready to trigger ovulation, we need to trigger ovulation and proceed with the treatment. When a GnRH agonist-based protocol is used, we have to use HCG. With the GnRH antagonist protocol, there's a lot more flexibility. We can use recombinant LH, and we heard earlier today that very high dose of recombinant LH is needed, and for financial purposes, this is not practical. But we can also use GnRH agonist to trigger ovulation. Now, when GnRH agonist is triggered, the egg yield, egg quality, fertilization rate, and embryo development is similar to the HCG triggered cycles, but the pregnancy rates are much lower. And I will have a presentation about this tomorrow. I will go into more details about this. It is the luteal phase that is affected by the GnRH agonist trigger, so the luteal phase has to be managed differently. Now, the luteal phase has to be supported in IVF cycles for various reasons. There are numerous explanations why we believe that the luteal phase is deficient. It could be due to the high steroid levels achieved in the follicular phase that result in luteal phase defect. It could be the removal of granulosa cell mass. It could be an altered steroidogenetic pathway as a result of the stimulation. And it could be that there's insufficient support for the corpus luteum in an IVF cycle. The luteal phase can be stimulated by HCG, progesterone, progesterone plus estradiol. Now, low-dose HCG is very effective but results in hyperstimulation, so this is very infrequently used. Progesterone is as effective as HCG to support the luteal phase, and by adding estradiol, we don't get an extra benefit, neither in the GnRH agonist nor the GnRH antagonist cycles. The only exception could be those GnRH antagonist cycles when an agonist is used to trigger ovulation. In those cycles, low-dose HCG or a more intensive luteal phase support may increase the pregnancy rates. So all these years resulted in the publication of many randomized control trials that compared the GnRH agonist and antagonist-based stimulation. And obviously, with the new data, a new meta-analysis was put together. There's actually two of them, one by Alinani, the other is by Kolibianakis, and both of them found no difference in the pregnancy rates based on 20-plus studies. So it looks like that over the past decade or so, we figured out how to use the antagonist protocol, and now they seem to be clinically similarly effective, the two stimulations. So this is probably the most important slide of the presentation. This goes through the pros and cons of the two stimulation protocols. And one important thing is cycle scheduling, and you can do cycle scheduling with the agonist stimulation. And if you use pretreatment with steroids, you can use cycle scheduling with the antagonist stimulation as well. On average, the stimulation is about a day and a half to 2 days longer with the long stimulation. Patients need more gonadotropins with the long stimulation. The GnRH agonist phase is associated often by side effects of hypoestrogenism. Though if you use pill or estradiol, then you need to consider the side effects of those with the antagonist stimulation, but still there are fewer side effects with that approach. The patients will like less injections, so there are at least twice as many injections needed in the long stimulation, which is a disadvantage of that. The OHSS risk is higher with the agonist stimulation. There's about a 50% reduction in OHSS risk with the antagonist stimulation, and this goes up to about 80 to 90% reduction in OHSS risk if you use a GnRH agonist to trigger ovulation. The clinical outcome is similar. Pregnancy rates are comparable with the two stimulation protocols. Patients obviously are more satisfied with the fewer injections, so the antagonist protocol offers this advantage. And at least according to the Hungarian prices, the two approaches compare favorably when it comes to expenses. So in order to conclude, currently controlled ovarian stimulation is still standard part of IVF. There are numerous stimulation protocols that we can choose from, and we always try to individualize the medication dose and the stimulation protocol. GnRH agonists and antagonists both effectively prevent premature LH surgeries, so they can both effectively used clinically. They result to comparable pregnancy rates, but the antagonist-based protocols offer other advantages, and I think that that should be the primary choice for both high responders, normal and poor responders. And with this, I thank you for your attention.
And while deciding for the fresh embryo transfer in the antagonist cycle, will you take serum progesterone on the day of trigger as into consideration?
We don't measure progesterone on the day of trigger. I know that with elevated progesterone, it's supposed to have adverse endometrial effects and pregnancy rates are lower. It is not a routine practice for us. We had a couple of cases when, despite the administration of the agonist as a trigger, we had suboptimal egg yield at the time of the retrieval. So what we do, we measure LH and if we use the agonist as the trigger, we measure LH and progesterone the day after that just to confirm the effect. But before triggering ovulation, we don't measure progesterone. And
will there be any difference in this serum progesterone concentrations between the long protocol patients and this antagonist?
Well, since both of them have a similar chance to lead to failure, about 3 to 4%, I imagine that there would be similar progesterone levels, but I cannot give you any personal data because we're not doing this routinely.
So any difference between the luteal phase support between agonist cycles and antagonist cycles?
If we use HCG to trigger, then we only use vaginal progesterone and we do not add estradiol, and there's no difference.
Okay.
If we use the agonist to trigger, then we follow the Humaidan protocol and we give low dose HCG on the day of trigger and continue with the progesterone support in the luteal phase.
Sir, if there is more follicles, is there any point in increasing the dose of set release from 0.25 to 0.5 to prevent the rupture? You got the point now? We follow them with 0.25 set release. So suppose she is having more number of follicles. To prevent the rupture, should we increase the dose of set release to 0.5 to rather than 0.25?
The dose of the antagonist?
Antagonist.
Well, the dose of the antagonist was determined in the dose-finding study, and the 1/4 milligram of the antagonist was found to be effective to prevent the premature LH surge. So to this regard, there's no point in using a higher dose. Now, the 0.25 already results in a profound suppression. So giving more antagonist, I'm not aware of any data that it would further cut the risk of hyperstimulation.
So if the estradiol level is high or the number of follicles are more, say 25, 30, is there no point in that?
We don't make a difference based on the follicle size. If the follicle number is high, if the follicle number is if the number of the follicles over 12 millimeters is over 15, then we will not use HCG to trigger, but we will use a GnRH agonist to trigger. And we feel comfortable proceeding with the fresh cycle. We don't freeze the embryos. Hyperstimulation risk is very low in these cases.
What is the cutoff of beta HCG 36 hours after your trigger? What should be the cutoff of
beta HCG?
Beta HCG.
36 hours after the trigger?
What is
I don't know any data about that. I think whoever does that measures the HCG just to confirm that the level was given. 36 hours after the HCG trigger, we already do the retrieval, so I don't think that the level makes a difference at that point. I may have misunderstood your question, though.
Yeah, exactly the same question I was, because we want to see whether the level of HCG is adequate, no?
Adequate for what?
For ovulation. For trigger.
Means you want to know whether she has taken HCG or not.
But I think
that is to study about, when we look at the literature of the MD follicle syndrome, we want to see whether the HCG level was adequate. You got the point?
We're not measuring HCG. The only time when we measure HCG, if someone is coming for the retrieval, and let's say we retrieve one side, and if we cannot get eggs, then we will get an HCG level measured, because we are looking for the answer why we are not getting eggs.
Sam, I've understood your question. In our LUF cases, we have tried finding out this, and we have levels, sometimes 16 MIU per ml, right up to 80 MIU per ml.
So can I answer?
It varies.
There is no consensus as of yet for beta HCG level. There is no value proven to be enough for the triggering of the ovulation. There is no value below which it is proven that there won't be any ovulation.
Peter?
But I think it also depends on how much HCG you give. The level will not be the same with 2,000 and 10,000. So I don't know if there's a cutoff, but I think the level must be quite variable.
Yeah, Peter, I have a question. Just like for the flare protocol, when you give just 2 doses of 0.5 GnRH agonist, and you can prevent a premature LH surge in 95%, 96% of cases. Is there any dose-finding study that after a single injection of GnRH antagonist, how long will it prevent a premature LH surge? Just a single injection of 0.25, not a depot. If you give, say, 0.25 at 15 millimeters or 16 millimeters.
There's probably data on that, but I think that the daily administration was recommended. The Q24-hour administration was recommended because it definitely lasts for 24 hours. But I imagine that it lasts for longer.
Yes, but the agonist was also recommended every 24 hours, the short or long protocol. But then with the flare stop protocol, it still covers 96% of patients don't have.
If you achieve suppression with the agonist, it covers at least another 7 to 10 days. So the effect is maintained. We participated in clinical studies when we were not allowed to give the antagonist on the day of trigger. So there it was more than 24 hours, about 36 hours up until the trigger, and we had no problem. So you probably could do every 2 days, but you may run into problem with some patients.
Sometimes when we start the antagonist protocol on day 2, we face the very high level of LH, like in PCO ovary. Would you start with antagonist first for 2 or 3 days to lower the LH, and then start superbly?
I myself have no experience with that because I put essentially all my patients on some kind of preparation, contraceptive pill preparation. And with that, the LH levels are also suppressed. But as I mentioned in the study, in high responders who have high LH levels, and PCO patients often have a disproportionately high LH level in the early follicular phase. If in those patients you start the antagonist on day 1, day 2, just with the stimulation, the cycle goes through quite well, and there are no side effects. But this is not personal experience. This is experience of other groups that were published.
Thank you.
One last question. Suppose you have a patient with long protocol whom you find to be susceptible to OHSS. Would you withhold leupride and convert the protocol into an antagonist protocol so that you can give a leupride trigger during the time of maturation? Would you do that?
It could be done, and as far as I know, you can give a high dose of GnRH agonist and it still could work. What we would do with the long protocol, we would offer coasting, and if we have to coast for more than 3 or 4 days, then we would just freeze the embryos.
You would not convert it into an antagonist?
We would not convert it. I think that if you wait too long, and if there's a long coasting period, then the endometrium suffers.
Absolutely.
So if you will end up freezing the embryos anyway, I don't think that it makes a difference. You may have a little bit less early hyperstimulation, but
then you will need to give
I don't
HCG
think that we
trigger.
are afraid of early hyperstimulation. I think we are afraid of late hyperstimulation.
No, the only advantage would be to enable one to give loop-right trigger, which would happen with conversion into an antagonist cycle.
I understand, and you could cut your rate of hyperstimulation that way, but if you end up freezing the embryos anyway, I'm not sure how much of a clinical benefit to that is.
Thank you.
Have you tried progesterone? Have you tried progesterone before starting an antagonist cycle to get the withdrawal?
I don't know where the question is coming from. I have not. Yes, hi.
Yeah.
I have not tried progesterone as preparation for the antagonist, but I tried the estradiol and it works just fine.
Okay.
And I tend to use the estradiol for the poor responders because I still wish for a nice cohort of follicles, as nice as it can be, but I would like to minimize the risk of suppression that one can achieve even with the pill.